As you know, glaucoma implants really have revolutionized the surgical success in glaucoma patients. Many of these patients had intractable glaucoma. They had failed filters, and the standard filtration surgery was really not effective. So Tony Molteno, developed the Molteno valve, one of the first Molteno valves shown here for these patients, and these proved to be quite successful in these type of patients. There are two types of valves. There's the non-valve, which is the standard Molteno valves, the Baerveldts valve, which is a non-valved shunt also, and then valve shunts, which have some sort of restrictor valves in them to quote-unquote help hopefully control the postoperative pressure. That's the Ahmed shown here, and then the Kruppen shown here. The Kruppen valve, I don't even know if they really make it anymore. The indications for glaucoma shunts have expanded really since the TVT study, which I'm going to discuss. But initially, as I indicated, glaucoma shunts were indicated in patients with significant conjunctival scarring, those patients who had prior retinal surgery, prior corneal surgery. They had previous trabeculectomies that failed. We tend to use them in complex glaucomas, including neovascular eye syndrome, uveitis, and aphakic patients. You really want to avoid bleb-related complications. The patients who you don't really want to bleb, those patients who are working out in the outside many times, working in industry or working in construction. We're very fearful of those patients having filtering blebs. So, hold on, let me go back here. So we want to avoid those. But really, since the TVT study, which I will discuss, we're now using them in really standard patients, phakic and pseudophakic patients, as a replacement for trabeculectomies. So just a little bit about trends. This is, of course, a little bit old, but we don't have a lot of new data. But just to show that Trabs have really gone down since 1994. They've been progressively decreasing. Tubes have been progressively increasing. And this, again, showing the increase in the number of tubes per year. So we're becoming more familiar with them, obviously. And then projected, actually, so if you actually looked at these trends, technically in 2010, which we're beyond that, there should be about the same number of Trabs and tubes that were being performed. And actually, I think it's true that we are now performing probably more tubes than Trabs. And many of the glaucoma specialists are really not, a lot of them are not doing trabeculectomies anymore. They're performing tube surgery as their primary glaucoma surgical procedure. The TVT study I thought was quite interesting, and I think this has spurred our sort of change in using using the tubes or the shunts for glaucoma surgery as the primary surgical procedure. It compared trabeculectomy with mitomycin C with the Baerveldts 350. So we do have to take into account that this was the Baerveldts valve, 350 valve. It did show that the TVT and the TVT study that the tubes had a hypertensive phase, which we know about. And at the 1-year study, there was equivalent outcomes of intraocular pressure. So it showed that when doing a trabeculectomy versus a tube, you had similar pressure lowering. Also, the shunt group did require more adjunctive medications than the tube group. The main feature here that we got out of this study was that the probability of failure was much higher for the trabeculectomy than the tube, which I think was somewhat unexpected. So the tubes, the trabeculectomies were failing at a rate of 13.3%, whereas the tubes were failing at a rate of 5%. So that's quite significant. And then they looked at this over 5 years now, and this is the 5-year data. And again, the tube versus the trabeculectomy group shows, again, similar IOPs. There's a little bit higher pressure in the tube group at 5 years than the Trab group, but really, basically, these were not statistically different. But again, the probability of failure was still statistically much higher in the Trab group versus the tube group shown here. And when they break this out and stratify the data according to the IOP that you would expect to achieve, so basically greater than 17 or greater than 14, still the tube group is doing better at being successful than the trabeculectomy group. So I think all this data has pushed surgeons to look more closely at doing tubes as, quote unquote, their primary therapy. So the Molteno-3 has come out. This is the new Molteno-3. It's a non-valved shunt with a pressure ridge. And actually it's this pressure ridge which I really do like, and I think it has significant advantage. It comes in two sizes, a 185 and a 245, shown here. I have really tend only to put in the 245 implant. I don't really see a reason other than for a pediatric patient of doing the smaller implant, or if you really had restricted access. And finally, they came up with this valve, and they moved the hole. They moved the placement holes forward, and the access is extremely much easier. So this change, and then they have a nice low profile. So it's a much lower profile than the original Molteno implant. It's actually a lower profile or similar profile than the Ahmed implant, and basically a low profile similar to the Baerveldts implant. So these are, again, overall much lower profiles. This is the new Molteno-3 versus the old Molteno with the pressure ridge. So again, here also they did move the suturing holes forward, but not as accessible as here. And they've changed the configuration, the design a little bit, so it's a little bit shorter, which I think is also better. So this is the one that we're using now exclusively, the new Molteno-3 245. Just again showing the surface area of the plate and the height and all these different parameters. When you look at the Molteno-3, the 185 and the 245 versus the Baerveldt 250, so now you have similar surface area. It's a polypropylene implant versus the silicone. Again, the sizes of the Molteno-3, a 16 millimeter plate length versus the Ahmed 16 millimeter plate length, either the S2 or the FP7. The width is 15 millimeters versus 13, so a little bit wider, but really not much different. So you're getting basically the surface area of a Baerveldt 250 with overall a size, at least a width of the Ahmed. And we know that a lot of people like to put in Ahmeds because, well, they're easy to put in. This is now as easier, if not easier, to put in than an Ahmed valve. And another reason, and it's giving you much more surface area than the Ahmed valve. So that is another reason that we find this to be the preferable valve over the Ahmed. Pre-op decisions, what type of valve? So we have choices: Ahmed, Baerveldt, Molteno-3. Ahmed valves, I think, there's a place for those. In patients with extremely high pressures, you need rapid IOP reduction. You really don't want to wait for your suture or your ligature to open. I still use the Ahmed valve. The Baerveldt, I think, is useful when, of course, you want to have a lower overall pressure over time. IOP in moderate control, which can be tolerated for weeks until the ligature opens or the tube opens. And then the Molteno-3, which I think we can use at any pressure level, and the reason is because of this pressure ridge. Where to place the valve, I think most of us, of course, do anterior chamber placement when we can. Deep chambers, open angle, patients can be phakic or pseudophakic. Ciliary sulcus or parts plated placement in patients with angle closure, shallow AC, PAS, patients with who had prior penetrating keratoplasty or even potentially DSECs now. We're doing a lot of DSECs. So we can put these tubes in the ciliary sulcus shown here. I mean, patients with neovascular glaucoma, of course, where there's really no angle. You don't want to go shoving the tube through the iris. And also, if you place these tubes too anteriorly, no matter what shunt, you can, of course, get erosion over the tube. So in these cases, I like to place the tube more posteriorly, if possible, put it into the ciliary sulcus. Likewise, patients with penetrating keratoplasty, if you can put these in the ciliary sulcus, especially if they have an ACIOL. I've shown it here. You can put the tube so it sort of sits over the ACIOL. That protects it from vitreous below. A couple of cases here. 70-year-old neovascular glaucoma, central retinal vein occlusion. They look like this. Hand motion vision, pressure's 47, PCIOL. iris rubeosus, angle neo, disc cup 0.7, which valve would you use? So in this case, I think you have a couple of choices. One, you could put in an Ahmed valve. I mean, we want to get the pressure down pretty quickly. The problem is that the Ahmed valve, as we know, doesn't always control the pressure and does not always prevent hypotony, so there is a higher risk of these patients developing postoperative choroidal effusions. The other aspect is to put the Molteno-3 in and ligature it. You can put a venting slit as well into the tube. I'll show you I have a video of how I do it. And then this will at least control the pressure somewhat in the short term, and then as the valve opens, you'll get lower and lower pressures. So my choice would either be the Ahmed or the Molteno-3, with the caveat again that if you're going to use an Ahmed valve, plan on getting a choroidal effusion and having to deal with it. So that's the advantage of using at least a semi-closed system or a closed system using an Ahmed, using a Molteno-3. The Baerveldts, as I indicated, I mean, you can use that also. It's just more work to put it in. The second case, 67-year-old pseudoexfoliation glaucoma. Good vision, pressures are 30, PXF material, PCIOL, 0.8 cup, so they have significant cupping, they got moderate visual field loss. What valve are you going to use here? I would not use the Ahmed valve in this case. A lot of people would use the Ahmed valve. They want to get the pressure down. They just say, okay, the pressure's 30, let's get the pressure down. I'm more concerned about the long-term efficacy of this valve and the long-term pressure. This patient's got a 0.8, maybe even 0.85, 0.9 cup, already has moderate field loss. I mean, they can tolerate a pressure of 30 for a little bit of time, so there's no urgency in getting the pressure down. What I want to do is I want to get a good long-term IOP control in these patients. PXF, as we know, is a tough disease, and these patients can get significant pressure rises. So this case, my valve of choice, and we just did this case recently, so that's why I'm bringing it up, is a Molteno-3. And I'll show you some of our data. So the Molteno-3, you can keep the system closed. You can put the venting slit in if you would like. And again, the pressure is opened up slowly. Issues with the Baerveldts, of course, the tube must be ligated or stented. I do that also with the Molteno-3. I think one of the big problems when we're stenting these, when we're stenting the Baerveldts, is that when the stent opens, I mean when the ligature opens, it's got to fill a huge space. And we've seen, I've been doing Baerveldts for many years, and before the Molteno-3 came out, it was either an Ahmed or a Baerveldt. And when the Baerveldt opened, I'd have some of these patients come in and they were coming in with choroidal effusions because it would open up, the pressure would go to zero, and they would not pressurize rapidly enough, and they'd develop choroidal effusion. So then I'd have to deal with, even 4 or 5 weeks later, I'm dealing with a choroidal effusion in these patients with the Baerveldt valve. So that, I think, is a big problem, and the pressure ridge and the Molteno-3s have really helped resolve that, virtually helped resolve that problem completely. Diplopia, of course, is a big problem with the Baerveldts, especially the 350. And then, of course, you have to spend additional time exposing the extraocular muscles and placing the valve properly beneath the muscles. The issues with the Ahmeds, I like the Ahmed valves. I'm not going to say that it's a bad valve. It does not require restriction to flow, which is great. It makes it faster. It does provide immediate IOP reduction. The problem is it doesn't prevent hypotony. So even though even though the idea is that it should kick in at 8 millimeters of mercury, we all know, those who do valves, that it's basically a crapshoot, and you never know what you're going to get for pressures postoperatively. I think the bigger problem is that there is a much higher incidence of encapsulated blebs in these patients and a more prolonged hypertensive phase. And so we do see this in the Ahmed valves, and we also know that the surface area is a little bit smaller. It's 185 square millimeters, and you don't get as good long-term IOP control. So in that patient I just showed you, who have significant cupping, visual field loss, you're not going to get pressures that are really below 18 millimeters of mercury in these patients long-term. So why use the Molteno-3? Again, I think it's got the profile's low. Of course, I like that low profile. The risk for erosion is much lower. Easy implantation with these anterior suture holes. No need to isolate the rectus muscles. The area is equivalent to the Baerveldt 250. I think that's very important. And this pressure ridge, as I said, now really allows for safer opening of the valve when the ligature dissolves. There's one other aspect to it, which is the pressure ridge actually reduces TGF-beta into the bleb, resulting in a thinner bleb. This is a slide from Tony Molteno. Here's the pressure ridge here, shown here, which would be sitting right there. This is the primary bleb. The thickness of the primary bleb, which is, in other words, the aqueous is hitting this primary bleb first, and then it will flow over into the secondary bleb, which is the rest of the valve area. And he showed that this is probably a result of the conjunctiva and the tenons being exposed to TGF-beta, inducing inflammatory reaction, which is why actually the Ahmed valves probably have thicker capsules, because they're being exposed to the, quote-unquote aqueous cytotoxins, and they get a thicker primary bleb. But then after that, not being exposed, so actually keeping the valves closed for a period of time, so they're not being exposed to the TGF-beta, they tend to form a thinner bleb. So in the long run, these patients do better long-term with lower intraocular pressures. And as I said, when the valve opens, it fills this first space, and then that's not a big space to fill. So luckily, they don't go in to get these, huge drops in intraocular pressure. Here's my video. It's a little bit long, but so I stent the valve with I use a 5-0 proline now to stent it. So I put that in. I've dissected the quadrant out. Basically, just make sure there's no adhesions, and basically push the valve in place. It's overall pretty straightforward. And I try to get it back a good 7 to 8 millimeters posterior to the limbus. I put 2 sutures. This way, a lot of people do a lot of strange things, but I just basically put the suture straight through. And it's easy to do now because you don't have to be manipulating and moving your hand sideways and everything. You just go straight on. So it's actually a lot faster. I also put a ligature here, or a positioning suture, basically just to prevent, in the case that if the valve were to be pushed forward, it would hit up against this stitch, so it wouldn't keep going. So I do that, and then I place my 6-0. I do a 6-0 vicryl ligature, and basically tighten that off. And I was doing a 7-0 vicryl also, so I don't know if this video shows it. I think I do a 7-0 also. So that I had variable dissolution rates, actually, because one suture was thinner than the other. But now I'm actually not even using the 7-0 anymore. I'm just putting in one ligature, because the pressure ridge has been great, because if that ligature, when it opens, it just fills the pressure ridge, and I really haven't had the concerns for the hypotony. So actually, I'm down to one ligature now for the Molteno-3 valve. You cut it, put it in. I actually use this. I pull the 5-0 proline a little forward. I use that as a stylet, and it goes right into the anterior chamber. And then I pull the 5-0 proline a little back so that you can see the stylet. You see the suture there. Then I've pulled the ligature, the 5-0 proline back towards the limbus, and you're basically done. Put on the scleral patch graft, and you're on your way. Here's my original. This was the article we published way back in, I don't know, I think it was in the 90s or something, where we had, this was the original Molteno valve. We put in the ligature. At that time I used nylon. I use the proline now, and then the 6-0 and the 7-0 vicryl. Then you could, if you wanted to, if you really were concerned the pressures weren't going down, you could pull it past the first ligature, and then you could pull the stent past the second ligature. And that way you could get controlled lowering of the intraocular pressure. Now, again, I said I just put in the one ligature, and I really haven't had to actually pull the stent anymore. I don't really pull it. I actually leave it in there because it seems to nicely fill that first pressure ridge, and then the pressure goes down nice and slowly. Again, post-operatively, this is what it looks like. We've had these blebs look really just great overlying the overlying conjunctiva. It doesn't appear thickened. We're not getting these encapsulation rates that we were getting with the Ahmed valve. So my experience, easy placement, minimal postoperative hypertensive phase, no postoperative hypotony. We've been getting gradual reduction, and the eyes are very quiet over these valves. We did a little study. This is just in the last 6 months or so, just looking at 12 of the implants that we did. Preoperative IOP was an average of 22. Postoperative, this is about an average of 4.5 months follow-up. Some of these are 6 months or so. But I think the interesting point here is that you see here, so day one, they're about 23 millimeters of mercury. And you'd expect to see this hypertensive phase right here around month one or so, month one, month two. We're getting really no hypertensive phase in these patients. The pressures are really slowly dropping. We're down to about 14, 15 millimeters of mercury. So we've been getting really great results with these valves and not seeing many of the problems that we've had with the other valves. Complications of the TVT versus the tube study, just to show, again, choroidal effusions do occur in the early postoperative phase. Flatter anterior chambers. So this is with the Baerveldts 350. As you can see, there were a significant number of these patients having flatter shallow anterior chambers with the valves. I haven't really seen this now with the Molteno-3. Late postoperative complications, of course, the biggest one is probably persistent corneal edema. Again, try to keep your tubes away from the cornea. I think that's the message there. So for me, when we're going to use a valve, we're concerned about the long-term pressure control, and I don't want to deal with choroidal effusions. I really have been using primarily now the Molteno-3. Again, as I said, surface area is an advantage. Similar effects, similar IOP lowering to Baerveldts. Pressure ridge, I think, has been a big advantage in my opinion as well. It's really helping, I think, reduce the complications, and I think making the valve a more efficacious device, I should say, in the body, because we're getting this thinner bleb in the secondary valve, the secondary bleb. Again, the non-valve design does avoid potential problems such as blockage or malfunction. Sometimes the Ahmed valves do malfunction or the valve gets blocked, then that's a big nightmare. And really, we haven't had any problems with diplopia. I think that's going to be relatively rare. We've had a small group of patients, but diplopia hasn't been a big issue. Of course, we know the Baerveldts that is a more substantial issue. I think it's a major advancement over the older valves. It's now my valve of choice, and I use that in many cases as still the primary surgical procedure rather than trabeculectomy. Thank you.